The upper fragment screw which is there is very near to the fracture. That's the reason it might have given way. And lower fragment should have more screws than the upper fragment. That's what I thought. Then the history of injuries there or lifting weights that can produce. Both. Was the plate in the medial side or lateral side?
Medial sides.
Anteromedial. Medial, anteromedial.
Anteromedial.
Okay. Or through. Right. That's what the. So what is this?
Sir, ILN.
It has crossed the fossa distally?
No, sir.
Not crossed. Movements of the after the surgery movements?
He is doing good, sir.
Flexion extension is in there. No. Graft is done.
Yes.
Okay. Right. Only one case you had?
Yes.
Only one case you had?
Yes.
1 week. 2 weeks or 1 week? 1 week.
Good morning, sir. This is a case done in Unit 3. It's a 20-year-old male with closed distal third middle third shaft fracture of left humerus with no DNVD. This is Holstein-Lewis fracture, sir. This is Holstein-Lewis fracture, distal third middle third combination fracture of shaft of humerus.
But you said no DNVD means what? What do you expect here?
Radial nerve is intact, sir.
So do you expect intactness here or injury to the nerve here?
Usually we will expect, sir, because it is at the Holstein-Lewis fracture, sir. But he is able to do wrist extension and finger extension.
What is the pathology I asked many times? Holstein-Lewis syndrome with radial nerve injury. What exactly happens here?
Here,
the diagram inside every textbook saying that this is what happens. Fracture lower 1/3 humerus where the lateral angulation is there. Nerve gets entrapped. When there is lateral angulation, not on the medial side. That's what the thing you should have shown.
Here,
why the nerve escaped here?
Because it comes from posterior to anterior, sir,
So
through intermuscular septum.
Site is same.
So,
The angulation should be lateral angulation
sir.
with the partially intact. Then only get entrapment. Otherwise, will not get. So all lower need not be Holstein-Lewis syndrome. That's what.
Lateral intramuscular septum is a tight septum.
Yes, sir.
Unyielding and inelastic.
Yes, sir.
So same thing in the flexor compartment. Deep fascia is unyielding and inelastic. So they give the compression.
We have done open injection, internal fixation through posterior approach, sir, in lateral position. 8-hole narrow DCP we have done.
Last screw is sufficient. Should not cross the opposite cortex.
Sir, cortex is intact.
Last screw. Yeah.
Yes,
Did it gone through the other cortex or not?
sir.
I don't think.
Sir.
Did not engage the
Cortex.
Yes, sir.
They are almost unicortical. And even the third from the bottom
Yeah.
also
Not got through.
completely
Yeah.
engaged the cortex. And also the locking, LCDCP was locking in the
Looks.
Yes, sir. Blade was bent, sir. Little bit. Yes, sir.
otherwise fracture will get opened up. And the LCPs are giving better functional results compared to the DCP.
What plate is this?
DCP, sir. Narrow
What
DCP.
is
8-hole narrow DCP.
Damn.
Narrow, small, and broad.
LCD. Not LCDC. LCDC, brother.
Sir.
LCDC means?
Locking compression with the DCP.
That's also compression only. Below contact, that's what.
Yes.
Right. Go back.
What are the indications for primary bone grafting in a fracture fixation? In the first primary fixation Are there any indications to prevent a non-union?
Wider gap between proximal and distal fragments.
You are not supposed to put gap. It has to be reduced anatomically. It is not the gap. Gap means your reduction is not proper. Bone loss. If the comminution is more than occupying more than the 1/3 of the circumference of the bone, then again chances of failure are there. If it is more than 1/3, and humerus is notorious for non-union after surgery. So 90% success of union when it is treated conservatively. Okay?
Yes, sir.
So chances of non-union are more if the comminution is more than 1/3 of the circumference of the bone.
Okay, sir.
Here there is comminution.
Yes, sir.
Go back. First X-ray.
Yes, sir.
So is it a significant comminution or insignificant? Appears to be a small fragment.
Yes, sir.
Okay.
Can be reduced.
Yes. In spite of the very good fixation,
Sir.
still sometimes these fracture fail to unite. Okay.
Yes, sir. Nerve exploration done, sir. Now exploration done. Nerve was intact, sir. Yes, sir. Yes, sir. After the surgery, yes, sir. He was able to do all the movements. Yes, sir. So. No, sir. There was no problem. No problem.
13-year-old male with intracapsular fracture of right femur. It is the Delbert type 2 classification, sir, transcervical. First we tried closure reduction with
Go back. Go back. Go back. How did you say it is transcervical?
here in lateral view, sir.
The second film with the traction and internal rotation.
Yes, yes, sir.
That you have to focus. So in this view, in the pelvis AP view, you don't, because it is in complete external rotation, you can't see the calcar here. No calcar seen in the first film.
Okay.
So that is taken with traction internal rotation. Does anybody guide the radiographer to take X-ray in this particular position, or they were tutored like that? Because most of the times we see these two films. Do they take this film, second film also on their own, or do you advise them to take?
No, sir, we.
No, I don't think. I think they are taking routinely. I don't think they are going to the X-ray department to take this X-ray. They will not go.
No, sir, for the
So
traction.
probably they were trained like that to take X-ray with the traction internal rotation. Yes.
For this fracture, first we tried closure reduction, sir, with lead-better technique, but the reduction was not satisfactory. Hip in 90 degrees of flexion, sir. Then apply the traction along the line of the femur. Then internally rotate, sir. After in the
9 degrees.
in the
Why you want to keep an external rotation and then internal rotation, then extension? Why? Each step has
Yes,
a meaning
sir,
there.
yes, sir. In hip flexion and external rotated condition, there are relax of the hip muscles and the Y ligaments, iliofemoral ligament.
That disimpaction
Yes, sir.
done with disimpact. Right.
Yes.
Next.
After that, internally rotate it, the Y ligament will be taut, sir, to fix the fracture alignment.
Then extend it so it will there extension. Capsule becomes taut. If the fracture is reduced, it will not move. Otherwise, it will move. So how to make out it is reduced or not? On table without even fixing. Other thing also, other limb also is there.
Yes,
So unless you have normal internal rotation, suppose compare the internal rotation of the normal limb to this limb, so that is reduced. Otherwise, it will not get reduced. That's what the problem is. Once you do that, compare the internal rotation of the normal
yes.
with the abnormal. If the rotation is the same on both sides, it is probably reduced. That's what. Still have to take CM only. Right.
Okay, sir.
So what, how many screws you have put?
3 screws, sir.
What the configuration?
One medial, central and
Is it a triangular shape or the divergent or convergent? Right.
regular triangles.
అంటే రెగ్యులర్ ట్రయాంగిల్ అంటే ఏంద్రా ఇర్రెగ్యులర్ ట్రయాంగిల్
Side. One screw passes along the central and medial, sir. First screw. It gives the compression, sir. Primary compression.
Do you think it will unite now?
Sir?
Do you think it will unite? Is the stepping of the calcar there?
No, sir. Fractures are aligned, sir.
Where is aligned? Now see the calcar femoris. I guess now there's a gap between these both these.
Fractures.
Combination ఉంటుంది అదే.
Yes.
Did you see in Siam during surgery?
Yes, sir.
I mean, combination is there.
Yes, sir. Combinations.
Okay. Or the TAD here?
Sir?
TAD.
TA.
TAD. చూడాలి కాదు కూడా either screw or DSS, whatever it is, let us see the TAD there. Compare the AP lateral view, perhaps the word. You do not know what TAD is?
Sir.
No, na? Tell her.
Go back to the first X-ray. See, is there any comminution? Lateral view is not there.
Neatly. Right. So most of the times you'll get the combination. That problem is that. And the gap also seen in the post of next day also.
Yes,
So much
sir.
of gap. I don't think it's very difficult to. Next time.
Complications like non-union and avascular necrosis, sir.
That will be there. Huh?
అంటే గుడ్ రిడక్షన్ అండ్
Yes, all fractures.
Specifically for children, what are the issues which are not there in adult practice?
5 is there. You want to injure 5 or not? Or you want to cross the 5 into the neck head?
ఎస్ సార్
Likely to produce damage to the growth plate, causing premature growth arrest.
But only one screw can pass through center, sir, which is right now. If it's one is enough to just cross it. But you have got 2 to 3. Yeah.
Can be smooth pins
Right.
or loose pins.
You are not available now. No prints.
High chances of AVN of
దిస్
even in the inline.
13 years, is it? Age?
ఐ సార్ 13 years.
3 is more for this. 2 should have been enough. Only adults you think of would do 3. But child 2 is enough to put. Even 1 is perfect in the center, that's enough also. But did you put spica here?
Sir?
Spica.
No.
Why?
Strict immobilization we advise, sir.
How?
After reduction.
Rigid
Rigid
fixation.
fixation. Good reduction.
But you are
and rigid
supposed to put
fixation.
spica. It will not hold.
At least if not spica, you
Yeah.
put a abduction bar.
Abduction bar and then
Okay.
Abduction bar is better.
every,
And Thomas Edward
every chance he may walk up sometime, it breaks. Right? When do you want to take up the screws?
After union, after union, sir. Union of fracture.
Okay. When?
Regular.
time taken, please take to heal the fracture.
1 year.
1 week.
6 months to
Okay, 6 months. It may be right. You want to take it after 6 months? Or keep it for a long time? What happens here?
screws will go inside, sir, after.
Breakage. Breakage is there. Best thing to
breakage
remove
of
it.
screws. Yes,
It's very difficult to remove breakage screws then. So best thing is once it unites with 6 to 8 months, the best thing to take it off. And the patient may come after 2-3 years. Once it is broken, they'll come again. That problem comes.
What is the size of the screws?
The diameter of screws is 6.5. Sir.
You were there?
Yes.
What is the diameter of this?
6.5, sir. 5 screw diameter.
Less damage, 4 mm. To produce less damage to the head and the growth plate, 4 mm screws are preferable. Okay, next.
74-year female with intertrochanteric fracture of left femur, sir. History of total hip replacement 4 years back, sir.
For
So
what purpose?
They are not giving proper history, sir, and they don't have any papers for that.
They don't have any record.
Yes, sir. No, sir.
Names,
They
sir?
are treated in names and that only there, sir. Closure reduction, internal fixation with the proximal femoral nails. Sir?
Nail is supposed to be flush with the tip of the trochanter. Why is it so? The stature of the person is statured, because these nails are designed for Western standards, and the same is copied by Indian company. That is the issue. Next.
A 74-year female with intertrochanteric fracture of right femur, sir. And we have fixed with PFN for the right femur. Yes, sir.
Next. 35-year male with tendon abscessor, extensor indicis and extensor digitorum tendons.
What is the nature of the injury?
Fall from bike, sir.
Fall from a height, how can it cause like that?
Sickle.
Cannot tear the tendon, huh?
Sickle cuts.
మరి fall from height అంటే అన్నిటికీ fall from a height. Not slip and fall. Is it an incised wound and lacerated wound?
Lacerated.
Sickle is very sharp. It can cause incised wound. Okay.
No.
He can't completely extend the fingers. Indices, sir. Only index fingers, sir. Other fingers are normal, sir. Yes, sir. Good, sir. At the metacarpophalangeal joint, sir. Yes, sir.
Why you said only both? Did you see anything there at the wound? Did you find out
Yes, sir.
where exact?
Distal,
Did you find out 2 tendons which are torn or only 1 tendon which is torn?
only one tendon.
1 tendon. Which one?
Distally one.
Right. Tell you. Did you see both the tendons which are torn there or not? What I am asking. Or only index is gone, the digitorum part index is gone. Unless you find 2 tendons here at the time of injury, did you clean the wound and see the tendons are there or not? Which is the area which is gone there? Which area of the wrist? Is it at the MP joint or distal to that? MP joint first. That's the area where you get capsule as well as the starting of the extensor hood. From there it starts. You should see that. And underneath that is the capsule where you can see any fracture was there?
Yes.
What fracture was there?
No fracture.
Yes. This is the MP joint, right. Right. And there is a flake of bone which was seen. That's what I want to say. Yeah. So direct injury onto the MP joint, where there is a flake of the bone which is gone, which is osteochondral fracture like then, plus the tendons have gone. So that's a quite deep wound. That's what you should say. Right.
No DM. Yes.
What did you check? So what do you want to check? Huh? What do you want to check? Is it the vessels or is it the now you want to check here? Huh? And how to check for the distal vessel now? Tell me. Anyone? How to check for the distal vessel injury? Either the wrist or the digits? Aim lever test, vascular test lever.
Allen's test.
Yes, Allen's test.
Allen.
So both, anywhere you want to see that compress and see it, you can have the distal vessels. Here, everything is exposed, but you can make out, suppose the injury is there, you can make out the vessels which are spurting. It was there?
No, sir.
No. So injury, no, I mean artery is intact.
No, I sir. Intact.
Right. So what did you plan?
We have done repairs at tendon repair.
Repair.
Yes.
Means?
Suturing the tendons.
End-to-end repair or
End-to-end.
tuneraphy. Primary tuneraphy is done.
Yes.
Both tendons or one?
Both tendons, sir.
Why both? Is there need to put indices also? Oh, one is enough, no? No, if the area is so tight there, if you want both tendons suture it there is the addition and then problem comes. Best thing is to suture only the longer, the distal. That function it's equally good. If you put both together under the capsule, every chance it may get additions there. Then the problem again will have to do tenolysis. So in these areas, two tendons and choose only one which is long one, then you can suture it. Yeah. Like.
Zoom.
Wow. Right. This is what? This indices or distal? What did you see?
Sir?
Ends of the cut ends of the tendon were they trimmed and debrided?
Yes, sir. Debrided, sir.
What? Here.
Distal.
Vital లేదా? Vital. Right. Now this is what you have sutured, right? Yes. But here this is the MP joint here. Now here part of thing which is there, flake of bone is raised. The head along with that flake of bone is raised here. And this is thing. Now if you want to suture both and keep it here underneath this capsule, the additions are common here. The best thing is to suture only the one which is big extensor. This torum only. Indices there is no need, you can just leave it or attach that to the same thing. Or you can do it. That's what you should always think. Two tendons are there, choose only one which is long, so it can have both. If you suture both together, there will be chance additions are there, then again problem comes with movements there. And the flake bone, what did you do?
One suture is important.
Yes, that's what. Flake bone can suture along with that. With the needles are there, which are called, big needles are, thick needles are there. Then you can suture only one and leave it. Don't try to put a pin here. That's what I said to Jairam. Just close it with a thick carrot, nothing, and then do this. But here what sutures you have applied? End-to-end anastomosis.
Yes.
You want to put cracos or bundles or modified bundles. What did you put?
Sir?
What type of suture you applied here?
Modified Kessler.
Extensor, tendon, extensor. You don't put all the big, only the flexors, you have to put all the cracos and then bundles. But extensor, just put an end-to-end anastomosis with a horizontal mattress. That's enough always. More the thing is the problem comes here. That you should remember. That's what they said. Right. 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 Indices. Is this indices or the
Indices.
Indices? That's what. What about other tendon? I think suture here.
Chest.
Which?
This is indices, sir. This is.
Which is indices, which is digitorum?
That's what I said. Confusion. Only thing, best thing is suture only this thing. X and digitorum only. Right?
Yes, sir.
Oh. You can't make out.
Indices is always medial to the digitorum slip. Medial slip is
Right.
indices. Why is it important?
It's
Not in this case.
okay, but now you should know this thing. What is I said? What is this?
When you want to correct
This.
the law hand,
Right.
take indices as a graph. Indices, extensor indices. That is on the medial side.
Right. That's what I said. Be careful not to suture both here. Think about it, right.
And the edges of the tendon
Yeah, trim really, yes. Yes.
non-absorbable suture, so that
Yes, sir.
it has a very good approximation,
Yeah.
so that it doesn't overlap and form lot of fibrotic tissue.
Did you immobilize or not?
Yes, sir. We know my blind
What position?
with extension and
Okay. Very photo initial mare. Extension MP joint. This extension
MP joint, sir.
MP joint.
MP joint.
Photo. Right.
Picture with the slab.
Slab వేసిన లేదా?
Yes, yes.
మరి right.
What is the position of immobilization? Very important. Which joints are kept in extension?
Wrist in dorsiflexion, sir.
Wrist.
How much?
MP joint extension.
How much of that?
Otherwise, what is the ball holding position? Position of function of wrist and hand. చెప్పు.
20 to 25 degrees of
Yeah.
and MCP joint
Cent-
also in dorsal.
Excellent.
That is where the digitorum
Grip.
acts. MCP joint.
Yes.
Other thing,
PAP joints.
flexion only, right.
Flexion.
Why not the PAP also in extension? Basics.
Yes.
The digitorum does not extend the interphalangeal joints. On clinical examination, you will observe whether by holding the MCP joint,
Are you able to extend or not?
observe at the time of examination, was he able
But
to
extend both, all the.
proximal and distal interphalangeal joint? Was he able to do? Obviously,
Yes.
he did not check.
They didn't check only tendons they have seen, then it's the thing. Okay, all things
The extension of both IP
should be
joints
there.
is done by the
Digital.
That's it. Intrinsic muscles.
So they flex the MCP and extend the IP.
Right.
That is called intrinsic
Mm.
plus position. Intrinsic plus. So the finger should be kept, the IP joints should be kept in
Flexion.
What intrinsic minus? You said intrinsic plus, no? Intrinsic minus? Opposite of that. Like law hand, intrinsic minus. Extension. Right.
and you should make a overlap of the sheath. If it is
Yeah.
it will not be damaged. The extensor tendon sheath should be covered over the anastomotic site so that it doesn't form adhesions
Adhesions.
between the skin and the other
Center.
subcutaneous tissue. If it is not traceable, at least you should make it like a sweep all around the anastomotic site
Yeah.
with the surrounding soft tissue.
After the suturing, did you see for the movement nice? It's moving or not? Sliding is good.
Yes.
After the
Yes.
suturing,
Yes.
did you close the capsule around it? Capsule.
Yes.
Close this area. Right.
The proximal end, you don't need to, of course, that
Mm.
may be the laceration.
Laceration.
Proximally it doesn't it retracts.
Yeah,
Distally
yeah.
it doesn't retract
It all attached here. Right.
because muscle is there with the proximal segment.
10 years male.
To immobilize
4 to 6 weeks.
flexor tendon
Extend surgery. That's-
10 years male with 15 months old post-op case of Perthes disease of right hip, sir, with implant in situ, sir.
So, what was done?
Varus derotation osteotomy, sir, with hemi-epiphyseal for GT, sir.
Very good. This is what, right. When was it done?
15 months back, sir.
Now, what's the problem for
Uh,
what's the problem has come with? Only removal has come, any problem is there?
no, sir, just
No removal.
Yes, sir.
He's happy with this surgery. No
Sir,
pain.
No pain, sir.
He's
No.
limping?
No, sir. No, sir.
He's not limping.
No.
He'll limp. Surgery is done nicely, but no pain, but still the patient will limp for a long time. That's what the problem here is. You have come only for removal of this, otherwise symptoms are not there.
Yes, sir.
But sometimes you can find even after surgery, everything has gone well, still the patient may have
Limbs.
limping, which is, you can't escape that, that has to be there, right? One yeah, unda surgery. Birth is. Dele vadu, number dele.
No, sir.
Yeah, containment. Yeah. Yes. That's what. Containment is good. And then. That was headed risk with that patient. What? Yeah. What's the age the patient when he came?
10 years.
10 years now.
At the right time, 8
8,
years.
7 to 8 years must have
7 to
come,
8
right?
years.
That was headed risk that time. They wanted to do this. No consent. Yeah. Right.
Implant removal done, sir.
Okay.
37-year male, 8-year post-op case of middle third shaft fracture of left femur sir, with implant in situ.
What was done? When?
8 years back, sir.
8 years back. No, what's the age? 37 years?
37. At 29.
30.
29 years.
Right done, అదే ఇక్కడ చేశారా?
No,
Here?
no, sir.
Not here, అదే అవుట్ సైడ్ ఇక్కడ చేసి ఇక్కడ చేయలే. నాట్ డన్ హియర్. బయట చేశారా?
No,
Elsewhere.
sir. Yes, sir. Elsewhere.
Within
Elsewhere, sir.
done in Myanmar or somewhere else? Myanmar only?
No, sir.
Hyderabad.
He's telling Hyderabad.
That's all right. Yeah.
Yes.
Go for this which is there. Luckily it didn't break. That's what Ligunde.
It's, normal, sir.
Even now.
Full. Yes, sir. Yes, sir.
Yeah, quadriceps. Yes, we used to do same thing.
We have done implant removals.
Yeah. So over on this is there, we'll get more bone here. Right. Okay.
37-year female with intracapsular fracture of left femur, sir. This transcervical fractures.
What is this something here? The normal or something? He had some fracture, huh?
We have done CC screw fixation for
Okay. This is what? Reduction was good. Exercise a bit less.
Yes, sir. There is
Impaction, right. Impaction next. Mm. Get into this. Mm.
so version and version.
Medial and lateral without steps, sir.
Then, nothing. Behind you're not sleeping.
No step should be present on medial and lateral sides.
Mm.
Lowell's S shape in the lateral. Lowell's S shape in the lateral.
Mm.
Yes, sir. Yes, sir. Lazy.
Mm. Mm. I think. This is a fresh fraction, no? Fresh again, not what. Mm. Valgus accepted or varus accepted? Valgus accepted, right? Impaction.
Inferior.
Inferior screw.
Most of the times we tend to accept. We don't make an attempt to make betterment in the reduction. How to see? Invariably, when it has gone into valgus, it is not under our control. Only the distal fragment is the one what is under our control. So how to bring this valgus into normal neck shaft angle? See, it is almost vertical. How to maneuver the head? You can take a 3.5 mm Schwanz pin and insert it into the head of the femur, into the up to the subchondral bone, so that it has got a good leverage, and then rotate it and try to bring it into alignment with the calcar femoral. So calcar is the most important alignment that you should achieve. Okay, joystick with a 3.5 mm Schwanz pin does not cause any damage to the head. That is the way in which you have to achieve the reduction. So here you see the head is, the screws are almost in the posterior cortex of the head. See, this is the head, no?
Yes.
They are almost abutting with the posterior cortex.
Diverge.
Three, keeping 3, you may injure the vessels. I mean the vascularity also. Always put 2. That's what I said. Right.
37 years.
Column construct is there, wall construct is there. CC screws of wall construct or column construct?
Wall construct.
Wall. So which is better, column or wall?
Column construct.
Then we have taken the wall construct.
So was DHS enough for this or not? Suppose I say I want DHS and leave it.
Yes.
DHS is a stronger one. Adult about 37 years, no? You can as well go for a DHS completely, right in the center.
Yes.
Well, it's very good and acts. I don't know why you put. These we apply only for the adolescent age and then children.
And all the screws are 6.5 mm.
Yes,
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 sir.
all.
6.5.
18 plus 1.5.
19.5.
On DH ఎంత ఉన్నది 12.5 13 single screw. So
Right.
that's why they're talking about PCCP also, percutaneous compression plating. But also they're talking. Can you, yes sir?
Where are we not talking of FNS?
FRCS FLS is a costly. Implant FLS is very costly. Implant
Next is the
Though anatomically these fractures are classified into subcapital, transverse and basal. For all practical purposes, if you observe when you are doing the AMP, hemi replacement, most of these fractures are spiral. Why they are spiral? These are all rotational injuries. All rotational violence produces
Spiral fractures.
spiral fractures. So there will be always a beak here, and the proximal part of the fracture line almost extends up to the head neck junction. So there, if there is a good neck length here and part of the neck here, we call it as transcervical. But most of them are transverse. Sorry, the spiral fractures. So the so-called concept of transcervical and subcapital may not be true, but basal is true.
yeah, basic not
You
move.
come to here, it is a true basal fracture.
But did you cross till the joint?
No, sir.
That what I asked is the TAD and the
Yes.
Indian. What is TAD distance here now?
Tip apex distance,
ఎంత
5
ఉంది?
mm.
AP lateral. ఎంత ఉండాలి? What is normal TAD?
5 mm.
25. 25. Both AP and lateral will be 25. Adi, in fact, asking so many times, sir. The theatre. A plus B.
Of AP and lateral
Till the tip.
tip of the
That should be.
screws. Yes.
Yes.
Earlier there was no term called as
Hmm.
DAD. The DHL was invented.
Then that's why it's there. Otherwise,
Parameters have come into application.
when you do SP nailing, then no, nothing was there. Right.
30-year male with 6 years post-op follow-up case of grade 1, grade 3B compound, middle third, both bone fracture of right leg, sir, with implant in situ.
Yes, come for what? Removal.
Demands.
Removal. Any problem you had on the medial side? Some beak is there on the medial side?
Yes.
No.
No problem.
But did you see the
Complete.
X-ray now on the medial
Yes,
side?
sir.
Is abutting
So
under the
bone-
skin. Is under the skin?
Yes, sir.
Beak.
It's under
what-
skin, sir.
What have you done for that?
Probably there must have been some butterfly fracture.
Right. But it's under the skin, definitely it's painful.
Luckily, it is all right.
Yes.
But there is no pain on the
No
medial
pain.
side. On that beak. Did you see?
Yes, sir.
That's all. Where is a segmental fracture,
Mm.
comminuted fracture, or open fracture, or simple fracture?
Open fracture.
Communicated,
right.
sir. Yes. Ekkade, sir. Communicated fracture. Close. Open, sir. Grade 3B compound. Sir.
What is the entry point for the vein? Where is the entry point?
Lateral. Lat. Lateral. Yes.
The condylar axis is parallel or something different?
This X-ray is not done in the true AP.
True plate. Fibula.
So you are not finding any interosseous space. The whole of the fibula is superimposing over the
Tibia.
frontal cortex of the tibia. That is why it is taken in a rotated position. Okay? It is not in the true AP.
True AP.
That is why it appears to be placed
Let-
laterally.
Is there shortening? No shortening.
Oh, shorting. Yes.
But it looks like shortening. Patient is comfortable happy.
Up to 1 centimeter shortening, there will not be visible
Complaint.
limb. Appreciable limb will not be there. Because the pelvis still compensates for that.
We have done open implant removal, sir. 75-year female with distal and both bone fracture of right leg, sir. We have done open reduction, internal fixation for fibula and close, sir. Sir? Fibula is supination. Is below the level of syndesmatics.
Is it an ankle fracture or a both bones leg fracture?
Both bone legs.
This one supramandibular fracture. It's not a component of the ankle.
Yes.
There is no involvement of the
Man.
Stable or not?
75. Very low social demands, physical demands, very low. You can align the fracture and treat it with a cerniotoplaster. Okay, of course, it's better to fix it. Is there any better way of stabilizing the tibia? It has been very well aligned because we have aligned the
First fibula first, sir.
topically with the contour plate.
Yes.
That is how this was achieved, yes. So with this, we cannot mobilize the joint early.
Yes.
Because
We applied the
you have to put POP for
For-
at least 6 weeks.
yes.
Why you are not fixed the tibia?
Anterolateral plating.
Handle.
Anterolateral plating. Probably this can be mobilized immediately after.
The swelling is more.
This being a metaphyseal fracture, they heal very fast. Metaphyseal area. Cancellous bone. It starts healing in 6 weeks. Okay.
And you have passed through the medial malleus also for the rotational stability.
So you will not open the tibial fracture.
Yes. No, not opens.
14 years male with 3 years post-op follow-up case of closed proximal third shaft fracture of left femur, sir.
All implant removal surgeries.
Implant removal,
So when it breaks, what do you do?
sir.
So when it breaks, what do you do? The holes are there still. If the advising not to work much or not to play, then problem is there. Yeah, implant removal is done. If it breaks again, the problem comes. Ask him to be very careful.
Because the amount, see the bone, the cortex under the plate is very thin. Medially it is okay. Cortex will be very thin because under the plate the bone will not form callus. Because it is
Compressor.
not supplied with surrounding, covered with surrounding muscles. That is why it is always a very thin muscle. At least for 4 to 6 weeks till the remodeling of the bone intraepithelial take place, we should avoid playing.
Where do the holes
They
get
can
filled
walk.
up? The holes get created now. When
Yes.
they get filled up, 6 months it takes.
Okay,
In that time, very careful.
okay, sir.
So go to the first plate. First plate. What is the indication for the plate?
No, sir. Skeletally immature patients. Skeletally immature patients.
Proximal rectum, proximal rectum.
Yes,
So he was 11 years at the time of surgery.
yes.
Okay.
7 years male with 3 weeks old Montage fracture of right forearm, sir. We have done.
What type of montage you have to also classify.
Yes, sir.
Whenever you see a fracture, try to understand that you should know some classification about each and every fracture.
Yes, sir.
More so in this type of fractures, not like routine fractures like
Baduk
tibial fractures.
type 1, sir. Baduk classification type 1, sir. Anterior displacement of the radius. Yes, anti-angulation, sir.
What is this gap?
Old one, sir. 3 weeks old. 3 weeks old.
Can you still manipulate here? Can you get?
Already callus is seen here. It is 3 weeks old, no?
Yes, sir.
Already there is built-in callus.
Anterior side. Yes, sir.
So true lateral view is not there. Both are oblique.
Yes, sir.
Anterior display,
We cannot
dislocation, anterior
achieve
elevation.
reduction by closed method because already the
Callus is formed. Open reduction internal fixation for plating for ulna and K-wire fixation for radius. Sir? Overcorrection of the ulna, sir. Approach, Boyd's approach, sir. We can open the annular ligament contracture also, and we can open the joint, and we can approach both radius and ulna, sir. Yes, sir. Yes, sir.
Voice approach is anterior approach, posterior approach.
Post approach.
So you can see the both of bones,
Yes, sir.
especially in old fracture. Not in
How much angulation is accepted here of the ulna? We reduce properly.
5 to 10 degrees. Yes, sir. Okay.
Unless you angulate the ulna, you will not get the reduction steady.
Yes, sir.
So always try to angulate the ulna posteriorly.
Yes, sir.
With anti-dislocation. Post-dislocation, anti-dislocation. That's what it is.
Okay, sir.
So when do you want to remove the pin?
After 2 weeks, sir. Yes.
So what is the angular flexion at the elbow?
90 degrees plus, sir.
This is 90. This is about 70 degrees flexion.
70.
Acute flexion.
Yes.
This thing is not more than 2 weeks to get out.
Okay, sir.
Ideally 90 degrees flexion. Ideally.
And the forearm should be in supination. Either supination, mid-prone or pronation.
Mid-prone, sir.
Supination. You should keep the forearm in supination. This is the position. Why? Why? You have to keep the forearm in supination. Why? To prevent recurrent dislocation of the radius. So after 3 weeks, you know how you are going to remove the K1. You put the otherwise there is high chances of redislocation or recurrent dislocation.
Only applying cash, supination.
Okay, next.
Already application is there.
81-year male, intertrochanter fracture of right femur. We have done close reduction with internal fixation with proximal femoral nerves. Sir, 50-year male came with fracture of both bone fracture of right forearm, sir. History of both bone fracture 6 years back, sir, and
Now what's the problem with this now? Again it is broken.
Again, it was.
yes, sir.
This is the fracture, right?
Yes, sir. No,
So what now? I want to see the management part, how to do it.
this radioulnar synostosis, is there, sir. Synostosis.
Congenital or post-traumatic?
Post-traumatic, sir.
What is it called?
Synostosis. Cross union.
Because there was a fracture in the
Proximal.
ulna also.
Yes,
Here. That is called cross union.
yes.
Which is a very, very rare complication in both bones.
That's because of the open fracture must have had.
Was it a open fracture at the time?
Segmental open.
Open fracture.
Yes.
Go back to the title.
No, sir.
Segmental fracture is there. No? Closed fracture. Closed, sir.
It was done where?
Sir.
Initial surgical was done there. Here only?
Here only, sir.
When?
6 years back, sir. After 1 month, they removed and applied slabs, sir. Immobilized for again 1 month.
What type of nail is this? Brush nail, tense,
Tense. Sir.
adhesive tension. Open these are incredible lumbar.
After 1 month of surgery, removed.
Right
Sir.
now show the X-ray now.
Can you say it is tense or
Rational. Rational. Tip. Rational. Yes, yes. So this is 6 years back. So 6 years back X-ray, sir. Came with both bone segmental fracture of radius and ulna.
Yeah. Where was it treated?
Here is.
All right, okay.
So for
So-
1 month, the rational is removed, sir, after surgery,
Uh-huh.
and immobilized for in cast for 1 month.
Right, okay. Was that right treatment? When was it done?
6 years back, sir. Here.
6 years back. Would you do the same or done differently?
Now they.
No, go back. Yeah. What? Would you do the same or do you do differently? Knowing the result.
It's different.
What way?
And radius.
Radius.
Yes, sir.
Yeah, probably ulna you can do intramedullary, but this one should be fixed. Nail will not, because there is a rotational element. Radius rotates, so invariably it goes into non-union and sometimes cross region. So should biological fixation plate would have been better. Yeah. Okay. So what are the problems now? Is it infected?
Not
No
infected.
infection.
So this is fresh
Sir,
fracture, sir.
Huh?
This is fresh fracture, sir. Yes, sir,
Again
fell
fell
down,
down,
sir.
right? Okay. How do you know before? Do you have X-ray before this?
He has
Is it non-union or fresh fracture?
fresh fractures.
Not well. I think probably, yeah. Doesn't look like, maybe unless you have X-rays of prior to injury showing union. Okay. No. Probably, did he have any disability or any complaints before this fall?
No, sir.
No, he was managing well.
Yes.
So this cross union was not causing any problems. Do you
So
think?
there is no supination.
There was no supination.
Pronations.
So Dr. Jagdish was asking whether you want to do two together or one at a time. Yeah, I think it needs fixation, but I think synostosis at this level, I know, that's also, but I think it's going to recur here, unless recurrence is very high at proximal. No, unless may have to interpose soft tissue. Okay, what was done?
Not done, sir.
Not. Which unit?
First unit.
Opinion, right? Probably, I think, see, this may be probably not in a medullary cavity is okay. Probably united, maybe united or not united.
You want to put a plate, you have to contour the plate.
No.
Because you can't chop off the cortex. You have to contour the plate.
So which one you fix first? Open first. Ulnar radius.
Ulna, sir.
Which one? Radius. Why radius? Or both together?
Radius should be
Radius. Why radius?
length of the
Because radius fixation. See, generally both bones, what are the principles? You fix the one which is not comminuted. or which is simple. But in this case, I think radius reduction is more important. That would be difficult one. So you
Here, you should not fix one bone and go to dissect the other bone. You have to open both at a time. See that both are opposed. Both the radius and ulna are opposed. Otherwise, if you fix one and then try to open the other fracture, you may leave a big gap. So try to oppose both the fractures so that there is a good contact. If at all it is necessary, if there is a gap, you have to nibble off some bone and then make them transfers. Make them transfers as far as
probably can shorten the ulna a little bit because it's there's positive variance. So.
because chance of union are less because the bones are sclerotic. Fracture side, the bones are sclerotic.
70-year-old.
Grafting is a must. Bone grafting.
Okay. Next. Oh, done.
Good morning, sir. Today's seminar about bone tumors. So bone tumors are classified.
This is not the contrast that we take up. Hardly any text is seen there. There
So
should be
simple
quite
one.
opposite.
Should be wide background and you don't have to reinvent these presentations. Already there. Okay. Can you change it now? Open it and change background? Yes. Okay. You change it now, somebody who is expert? PPT. Can you help him? Make white background. Apply to all. Yes, that's better. Okay. Apply to all. Yes, very good, excellent.
So bone tumors classified as primary bone tumors, mainly
Full
malignant.
screen.
60 slides.
60. Quickly, okay, go on.
Primary bone tumors and secondary bone tumors
Okay.
forms 0.2% of tumor burden. Primary malignant bone tumor makes 1% of all the malignant tumors. Commonest bone tumor is secondaries from the other sides, and commonest primary bone tumor is multiple myeloma, and second is osteosarcoma. So this will be coordinated with 3 persons: clinician, orthopedician, and radiologist and pathologist.
Good.
So tumor, we will see the age of the patient and sex of the patient. It is single or multiple, and which bone is affected, and which part of the bone is affected, and morphology of the lesion. That is border, bone destruction, periosteal reaction, matrix, and soft tissue matrix. So for patient, we should attend clinical history and physical examination, mainly complaints of mass, swelling, which is painless or painful, and swelling, progression, which is aggressive progressively or gradually progression, and will diagnose with the radiography, CT scan, MRI, PET scan, and scintigraphy. So rule of in the lesion, we should follow rule of 8 to describe the bone lesions. So age of the lesion, location, size, zone of transition, pattern of bone destruction, periosteal reaction, tumor matrix, and polyostotic or monoostotic.
Where did you get this picture?
Google, sir.
Google, right? Not the textbook.
No, sir. Yes, sir. Same.
Huh? Right. There's a good one. Aptly. Yes, you were saying. Go on.
The site of the lesion, epiphysis, metaphysis, and diaphysis, and border of the lesion, sharp, narrow zone of transition, matrix, whether it is cartilaginous or osteoblastic, periosteal reaction, it is solid, interrupted, or solid, or non-interrupted, and bone destruction, it is geographic, moth-eaten, and permeative, and soft tissue extension or mass. So age of the patient, around malignancy of Ewing sarcoma and osteosarcoma are below the 30 years, and most of the malignancy are more than 30 years, and benign tumors are almost less than 30 years. The age of by age of the patient. It's the borders of the patient.
Pictures are from a textbook on bone tumors called Greenspan.
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 Oh, right.
Exclusively on bone tumors. All these pictures
Nice pictures.
The border of the lesions are sharp and poorly defined border. Sharply outlined sclerotic border, the narrow zone of transition. This is a benign, and in a malignant, wide zone of transition. And a lesion central or eccentric. Central lesions are simple bone cyst, enchondroma and fibrodysplasia. Eccentric are giant cell tumors, non-ossifying fibroma, aneurysmal bone cyst, and chondromyxoid fibroma, osteomas. These are the borders: sharp sclerotic in non-ossifying fibroma, sharp lytic lesion in osteoclastoma, and ill-defined in myeloma. Examples. So the immature skeleton and mature skeleton in malignant conditions. In immature skeleton, chondrosarcoma, osteosarcoma, and Ewing sarcoma. In mature skeleton, malignant fibrous histiocytoma, myeloma, osteosarcoma, lymphoma, and metastasis. So the examples of malignance and benign tumors. So the benign lesions and malignant lesion differences. Benign lesions, well-defined sclerotic border, lack of soft tissue mass with solid periosteal reaction and geographic bone destruction. In malignant, interrupted periosteal reactions, moth-eaten or permeative bone destruction, soft tissue mass, and wide zone of transition. Differences. The examples of benign and malignant. Benign aneurysmal bone cyst, benign fibrous histiocytoma, bone abscess, chondroblastoma, chondromyxoid fibroma, inclusion cyst, fibrous cortical defect, fibrous dysplasia, intraosseous ganglion, medullary bone infarct, non-ossifying fibroma, osteoblastoma, osteofibrous dysplasia, periosteal chondroma, and simple bone cyst. Malignancy: chordoma, chondrosarcoma, osteosarcoma, and some malignant tumors after treatment of radiation and chemotherapy. Benign and malignant. Enchondroma in a short tubular bone, benign gain cell tumor which is aggressive, bone tumor in hyperparathyroidism, osteolytic phase of Paget disease, and osteomyelitis. Malignant examples are myeloma, fibrosarcoma, malignant fibrous histiocytoma, telangiectatic osteosarcoma, lymphoma, telangiectatic osteosarcoma, and angiosarcoma, and metastatic tumors primary from lungs, GIT, and kidney, breast. These are the geographic lesions. Examples of giant cell tumor with well-defined margin. Moth-eaten, examples of osteosarcoma and myeloma. Multiple moth-eaten legs. And permeative, very small, ill-defined. Examples of Ewing's tumor. The periosteal reactions are, which is uninterrupted and interrupted. In interrupted, sunburst appearance, perpendicular, and lamellated onion skin appearance, and Codman strangle. In sunburst appearance, examples are Ewing's and osteosarcoma. In lamellated onion skin, osteomyelitis and Ewing's tumor, mostly. Codman strangle, osteosarcoma. In uninterrupted periosteal reaction, which is solid buttress type, examples are osteoid osteoma and chronic osteomyelitis. In solid longitudinal uninterrupted, examples are hypertrophic pulmonary osteoarthropathy, thyroid arthropathy, and varicose veins. There are the chondroblastic and osteoblastic changes. Chondroblastic are annular, popcorn-like, and comma-shaped calcifications in the lesions. And then osteoblastic, examples are enchondroma and chondrosarcoma. In osteoblastic lesions, fluffy, cotton-like or cloud-like densities in lesions. Examples are osteosarcoma. No obvious mineralization is seen, sir. No chondroblastic and osteoblastic region. Examples are unicameral bone cyst, aneurysmal bone cyst, non-ossifying fibroma, fibrous dysplasia, giant cell tumor, and plasmacytomatous myeloma. So differential diagnosis and differences between primary soft tissue tumor and primary bone tumor. Primary soft tissue tumor is epicenter is away from the bone cortex. outside cortex, and in primary bone tumor within the bone epicenter. And cortex bevel towards the bone and cortex bevel towards the soft tissue. Periosteal reaction absent in soft tissue tumor and periosteal reaction present in the bony tumor. Size of the lesion, small bony lesion and large soft tissue mass seen in the soft tissue tumor, and in bone tumor significant bony destruction and small soft tissue mass. So role of cross-sectional imaging. Computer tomography used to know the exact anatomical extension for surgical planning. Cortical lesions are better evaluated by CT in osteoid osteoma, periosteal reaction, matrix mineralization and lesions in flat bones. Staging done by both CT and MRI are useful, and for a guided biopsy CT is used, and for radio frequency ablation in osteoid osteoma. Ultrasound is usually used in biopsy if the lesion is associated with extensive soft tissue component and amicable to biopsy. These are the MRIs used in MRI. Mainly we will see the more marrow and tumors. Red bone marrow T1 weighted is low intensity and T2 weighted high intermediate intensity, and tumors in T1 weighted intermediate intensity and T2 high intensity. T1 versus T2 weighted images, sir. In malignant fibrous histiocytoma, in A and B, sir. This is A and this is B, sir. T1 weighted, low intensity signal is the tumor, and high intensity signal is the marrow, sir. In C, T2 weighted image, high intensity is tumor and low intensity is marrow. High intensity is radio opaque, white color. The contrast MRI is seen 14 years old osteosarcoma, sir. In T1 weighted, low intensity marrow and the tumor. In B, heterogeneous enhancement of the bone tissue and soft tissue. CT scan versus MRI, Ewing's tumor, sir. Example, X-ray is a moth-eaten destruction and aggressive periosteal reaction. In CT, cortical destruction and periosteal reaction and no soft tissue delineation. And in MRI, large soft tissue mass adjacent to the fibula to osseous lesion. Bone scintigraphy. Radionuclide isotope bone scan depends upon the vascularity described as increased uptake. Picks up inconspicuous lesions on X-ray and also skipped lesions and multiple metastases. PET scan. Fibrous dysplasia patient. Whole bed scan, multiple deformities and red areas include hypermetabolic foci. Other diagnostic modalities, special tains, immunohistochemistry, antibodies, electron microscopy, genetics, flow cytometry, cytogenetics, molecular cytogenetics and polymerase chain reaction. So biopsy, this biopsy is performed after the imaging evaluation is complete. Types of biopsies, fine needle aspiration.
This is important one.
Yes.
That's what we discussing last time. Now you understood, everybody? That's what you do. Go on.
Fine needle type aspiration, core needle, incisional biopsy and excisional biopsy. The tissue obtained in fine needle aspirations are cells. In core needle, soft tissue core. In incisional biopsy, adequate sample of mass or lesion. In excisional biopsy, entire lesion is removed. So advantages and disadvantages.
So in bone biopsy, fine needle cannot get the material.
Yes.
Bone tumor. So it is always the
Core needle.
Generally, this is not done. This is not done fine needle, unless it's a soft tissues.
Special stains and immunohistochemistry. Eosin and hematoxylin for chondrosarcoma. Wang-Gassen stain is for fibrous dysplasia. Gomori stain for fibrous dysplasia. Jimsa stain for lymphoma. Periodic acid shift base stain is for extraskeletal myxoid chondroma. Novotny stain is Ewing sarcoma. Wang-Gassen stain for fibrous dysplasia. chondrosarcoma, H&D. Histopathology to rule out low-grade malignancy and high-grade malignancy with well-differentiated.
Didn't take it, sir.
For low-grade malignancy and high-grade malignancy. This is the low-grade malignancy. The upper one is the low-grade malignancy. Well-differentiated, few mitotic figures, moderate cellular atypia and moderate nuclear atypia. In high-grade malignancy, de-differentiated, abundant mitotic figures, abundant cellular atypia and abundant nuclear atypia. The other tests, antibody test and electron microscopy test. Antibody tests against intermediate filaments, against hemopoietic and lymphoid cells, against vascular antigens and against muscle antigens. And electron microscopy is very rarely useful. For spindle cell tumor, metastatic deposits, detection of myofilaments and basal lamina, and leiomyosarcoma. So Enneking staging for benign, we used Arabic numbers, and for malignance Roman numbers are used. For benign, stage 1, 2, 3. Stage 1 remains stationary or heals spontaneously with indolent clinical course and well encapsulated. In stage 2, active disease, progressive symptomatic tumor growth remains intracapsular and limited by natural boundaries which are frequently deformed. In stage 3, aggressive disease, aggressive growth not limited by capsule or natural boundaries and may penetrate cortex or compartment boundary, higher recurrence rate. So for malignant, Roman numbers are used. In stage 1, 2, 3. Stage 1, histologically low grade and well differentiated, few mitosis, moderate nuclear atypia, tends to recur locally and moderate radioisotope uptake. In 1A, it is intraosseous or intracompartmental. In 1B, in they are extraosseous or extracompartmental, penetrate cortex. In stage 2, histologically high grade, poorly differentiated, high cell to matrix ratio, many mitosis and severe nuclear atypia, necrosis and neovascularity. Permeative osteolytic destruction and intense radioisotope uptake. In 2A, intraosseous or intracompartmental, and 2B, extraosseous or extracompartmental. In stage 3, metastasis is present and regional remote metastasis, viscera and lymph nodes, bones, other bones. Treatment, sir. Treatment for bone tumors, like it is a combined adjuvant therapy by radiation therapy, chemotherapy and surgical technique, by limb salvage, amputations, curettage, resection, reconstruction and rotationoplasty. These are some examples of chemotherapeutic agents. Yes. These are the levels of amputations: intralesional amputation, marginal amputation, wide amputation and radical amputation. These are the curettage techniques. These are the examples of malignant bone tumors. Brief explanation of malignant bone tumors. These are the
I think this one probably
basics of
okay.
yes,
What are all the investigative modalities and what are the basic types of
treatment.
Individually we have to
That is a big chapter.
Chapter.
You cannot cover it. So if you know the basics in this class, clinical presentation, diagnosis and base line treatment. Okay.
just go through the conditions, but I think just enumerate how many slides are there?
Next 20, sir.
Okay, just conditions. Okay.
Conditions. Multiple myeloma.
Probably you stop here. Next individual conditions we'll discuss later.
Important common tumors. Benign,
Malignant.
Okay.
These are the malignant tumors, sir. Multiple myeloma, commonest bone tumor, multiple myeloma. Sir. These are the examples of multiple myeloma. Punched out lesions, moth eaten, permeatives. It's osteosarcoma, sir.
Next.
Examples of osteosarcoma.
So individual tumors we'll discuss later. Huh? Okay. Well, excellent. I think if you remember or retain about 20% of it, I think you will be able to manage our bone tumors well, and you should be able to pass the exam as well. So bone tumors very, very important. You can't get away without bone tumors. Excellent.
This is done in Unit 2, sir. Osteochondroma of right proximal tibia. So,
All right.
20 years male, sir. This is the clinical pic. Swelling at the.
Yeah, we've seen this one. Okay, go on.
This is a pre-op X-ray. The intraoperative X-ray.
We've seen this one, yes, last time.
This is a post-op follow-up, sir.
4 months after surgery.
Yes, sir.
Yesterday.
Excellent. So you do one case presentation of this one. In a chart, we will display in the department. And also, who was involved? Were you there for the case?
Yes, sir. Abhiram is there, sir. He is presenting the case.
You present it for the meetings, national meetings. Say next Tosakan, you can present this.
Yeah, presenting, sir.
Good. Excellent. And
Interesting case for the Tosakan. Tosakan also can present. Still time is there.
So this is a 8 years female, sir.
Picture.
So,
There is a clinical picture.
there went, sir.
call them back, and you have telephone number?
Yeah, she is coming, sir, today. So the 8 years female complains of pain in the right knee joint, sir. So, the acute condition for since 8 days, sir. No history of fever and no history of any trauma, sir. So X-ray.
X-ray.
Is there pain at rest?
Yes, pain at rest. Yes, pain at rest. Pain at rest, sir. No night cries. No.
Systemic symptoms, fever?
No, sir. No
fever.
No fever.
Okay. What do you go back?
Now you have made a presentation.
Yes, sir.
Now you should be able to
Describe.
So,
describe the region and make a
by age, this is a less than 10 years, sir. And lesion, skeletally immature patient, distal femur, with periosteal reaction. No, sir. Includes metaphyseal.
So is it epiphyseal, metaphyseal, diaphyseal?
Metaphyseal.
Metaphyseal.
Metaphyseal region.
number one age, which bone, which part of the bone, like that.
Metaphyseal region with the sunburst appearance, sir.
Is it intramedullary, artical, or extramedullary? Or extramedullary?
With extension.
What type of destruction is there? That is very
Permeative destruction.
permeative, yes. Next. It is not a lytic lesion.
No, sir. Permeative lesion.
Next. Zoom the picture.
Is it extending outside the bone?
Zoom, yes.
Yes, sir.
Yes.
So it's extending outside the bone.
Yes, sir.
Yes. Type of destruction, and then the type of periosteal
Reaction. Sunburst.
sunburst.
Perpendicular.
You can see sunburst appearance.
Is there a Hartmann's triangle?
Yes, sir.
Yes.
Okay.
Is there soft tissue swelling?
Yes, sir.
These are all very important features for making a diagnosis.
Yeah, loss of normal tissue. Fat planes and the soft tissue. Okay.
The growth plate is not affected.
Not affected.
So is it showing the signs of benign or malignant?
Signs of malignancy.
Malignancy.
What are the differential diagnoses?
osteosarcoma and Ewing sarcoma. Mostly osteosarcoma, sir, with sunburst appearance. Diaphyseal Ewing, sir. It extends to
Ewings more common in diaphyseal,
diaphyseal.
but it can happen in metaphyseal as well. Gone. So what else you want to do? Investigations.
You have not taken the X-ray film?
No, they didn't. No, they. MRI patient is not sedated, sir. She is not cooperative. They will come to today, sir. Child.
Really. So always you should have gone.
You should take the X-ray picture, not the screenshot. Because screenshots are not to be dependable.
But they can give a soft copy. Take a soft copy.
Okay.
There appears to be some permeative destruction all along the shaft. Compared to the left femur, you can see that. Compared to the left femur.
Yes. If you get MRI scan, yes, you are right. It's going to. So only 10, how many days so? Symptoms?
8 days, 10 days, sir.
Maybe longer, maybe longer. Find out. It can't be 8 days.
Transition is very good.
So what are these X-rays you taken?
And there is a history of surgery at the right shoulder joint, sir.
Right.
Reports.
So you done skeletal survey.
Yes, sir.
Okay. So probably next time we should be able to get investigations.
Fine. Bond.
And investigations maybe can get through cut biopsy then.
Yes, sir. Okay. Okay, sir.
Otherwise, first doing regular MRI and then again doing contrast MRI is not a good idea.
Okay.
Why contrast MRI is important? Why contrast MRI with gadolinium? Gadolinium
So-
and MRI.
soft tissue.
Why is important? Soft tissue.
Soft tissue.
Most important. 8 years old, female child. Is it malignant or non-malignant? That is most important. Benign, malignant.
Gives a tumor enhanced.
It will be infective. Children don't think that.
Delineated in the plain MRI.
Fine. Yes.
So the tumor uptake will be better with the radioactive.
Vasculature will be better.
Better.
And in
What is the plan? MRI is done. It is also concerned with the diagnosis of osteosarcoma. Looks like a typical presentation. Can it be osteomyelitis?
already it was taken as something operations. What for operation?
Differential diagnosis should put it.
You should always keep it in mind.
So if you're taking a biopsy, which site would you take? Where do you take? Which part of the femur you take? Anybody? Nobody? All. Second years are not. Where do you take biopsy? When you're taking a biopsy for tumor, what are the consideration? Okay, you take growing, what is that, active or a growing end of the tumor. Which side? Anterior, posterior, medial, lateral of the femur? You must include the scar in the final operation you're planning for. So you should not take it from lateral side, take it from medial side. In a tumor surgery, we expose the vessels and then excise the tumor parts along with the bone. So,
Including the whole pack
right.
of the needle pack.
So the scar, what is the biopsy site should be included in future excision.
If you are not the surgeon who is going to treat this, further.
Not do biopsy.
Ideally speaking, the surgeon who
Sure.
is going to do the
Final
definitive
operation.
surgery for this tumor is the
Do
ideal
biopsy.
person to take a biopsy.
Biopsy.
Because he knows what is the
But-
future plan of surgical management. If at all it is to be treated by surgery, he is the best one to plan the site of biopsy.
Or you can consult him and discuss with him, then decide. Very good.
So what are the basic lines of management? Just in 2-3 sentences. Have you read or not read?
Yes.
Not much of time.
I learned about the principle.
Hmm.
So when you got a different cases, you said radiology, you said pathology, and you said clinical findings. Still, there is a doubt, simple. Molecular studies, it is done, it means, study for molecular studies.
That's what tissue studies nowadays, they can do it, but
Different cases.
what would be surgical principle? Osteosarcoma, which is the definitive treatment if you think it's osteosarcoma or Ewing sarcoma.
Resection.
Yes, radical excision,
Excision.
limb salvage surgery. Radical excision and
Limbs.
reconstruction. Have you seen any? No. We'll discuss.
Before surgery, anything needs to be done.
Chemotherapy and radiation. Neoadjuvant.
Reduces the size and the aggressiveness of the tumor, which makes the surgery more easier.
Easy.
Yeah.
Neoadjuvant chemotherapy.
Chemotherapy, probably they do 3 cycles before and post-operatively probably 3 more cycles. Yeah, you wanted to say something?
The chance of 5-year survival rate are better with neoadjuvant chemotherapy and radical surgery.
Survival is very good for, if it is not metastatic, if it is within the, but it's, I think it's extended. Yeah, extended,
I think there's gone intramedullary.
intramedullary
More
probably.
proximal.
And probably radical excision means entire femur replacement. If it goes on along the medullary canal, then. Okay, good. Anything else?
Consult a oncologist.
Probably, yeah. I will give Rajiv Reddy number. Can you speak to him? Speak to him, send the images, and then probably poor patient. Meer maatadam better. And if it is, we can come and do it here. Demonstration. Yeah, yeah.
Where to do the biopsy, location.
That's it.
After a long time we are seeing.
Oh, very good. Excellent, excellent case. Most of the time they are going into other centers, but I think it's how many cases pending in Unit 1? Unit 1? 2?
4, sir.
3? No. Oh, that's excellent. Yeah. Very good. If we can, that's what, if we can remember, retain 25%, I think that's very good.
Good job.
Very good, excellent.
In a brief manner.
Good.
అది బొమ్మలు పెట్టాలి, అది బొమ్మల స్టడీ. నేను చేస్తున్నావు కదా, ఎవరికి వెరీ గుడ్. కాకపోతే ఇదో కొంచెం ఏ గురించి మాట్లాడదా, ఏ